So just really quickly, some of the demographics, while we were representative for certain things, we were not representative of the general national population with respect particularly to education level and household income. Our survey respondents generally were more affluent and better educated, and we used that as a variable that we could analyze to see how much that pushed responses one way rather than the other. Another characteristic of the population that was sort of interesting background we collected was how much trust they had in their physician and in their healthcare system. And as you can see, there was quite a bit of trust in their clinicians and in their healthcare system. I should also add, we didn't include this, but we also found out that a lot of them had serious health issues. So a very high percentage of the population, I think it was around 40%, had a health condition of some sort that was that required seeing a specialist and had family members. So it was quite a lot of experience with the health system. So the first major finding from our empirical study was that there's very strong support for research on medical practices. And this should be unsurprising given a lot of the things we've been hearing from a lot of the patient advocates earlier today. 74% strongly agree and 23% somewhat agree that health systems should conduct research on medical practices. And even when it includes randomization, the vast majority believe it is always, usually, or sometimes acceptable for healthcare systems to use randomization to compare how well treatments work. This actually was also reflected in our earlier focus groups, and just a couple of quotes to illustrate this is from our focus group findings. It makes me feel secure that they're studying these practices to determine how to improve, so you know these practices are under an umbrella of constantly, how can we make these better? Research is just very, very important, which is, I'm sure, why we're all here. Research is very important. And part of the reason why patients supported this was because of the recognition that they themselves were the beneficiaries of past participants in research. I'd love to benefit from it, but I'd be okay with just finding out whether good or bad if it affected me better, because somebody else down the line will benefit from it. So ultimately, that's where I'm looking at it. Someone prior to me actually went through a study, and that's the only reason that I'm on the treatment that I'm on now, so I see the benefit of that. My son is 16, and we've had 16 years worth of improved care because of other people taking the steps and doing the research and improved options for him, and I wanted to be able to give back to that. So altruism clearly played a role in their willingness to participate. In terms of back to the quantitative data, patient support for research is also reflected in the fact that most of them were willing to participate in research, though as you can see, a higher percentage were willing to participate in research when it's medical record review versus randomization and randomization to a more serious condition. Based on our focus group findings, we looked at a number of different elements to see whether or not those were factors that would influence willingness to participate, including knowing my physician recommended participation, knowing that this is the only way to find out which medication is better, knowing I could change the medication, knowing which medication I was taking. All those things our focus group suggested were important, and sure enough, our quantitative data confirms that those were important to making people more likely to or willing to participate in research. Demographic predictors of willingness to participate in research included higher income, prior participation in research, better understanding, so the more they got the answers correct about research on medical practices, the more likely they were to participate, more trust in their physicians and health system, support for research in general, lower perceived risk of ROMP, less stringent notification and permission preferences. So overall, the first take-home lesson is that there's a lot of support for research, and that the public and patients really do want this research to take place. Second finding is about notification preferences, and unsurprisingly, people want to be told and want to give permission for the research. And you can see this, the majority want to have discussion plus written permission, with just a slight majority, and others are okay with just leaving it at verbal permission. But if you put those two together, they want to have discussion, they want to be informed, and they want to give permission for research to take place. One other interesting point about this, though, is to note that there's really, and I'll come back to this later, there's really not a lot of difference in that preference between whether it's research involving medical record review or randomization. So whether it's medical record review or randomization, patients want to know, they want to be told what's going on, and that's their strong preference. But one question to ask is, what do you do when those things are in conflict, which is really the whole point of a lot of the discussion today, because sometimes having the more stringent the consent requirements, the more challenging it can be to carry out, the more expensive it can be to carry out, and so sometimes the more stringent consent requirements may be incompatible with the ability to carry out the research. So what's the relevant rank ordering of this preference, since most people want to have stringent consent and they also want the research to take place? So we asked if getting written permission or consent would make this research using randomization too difficult to carry out, how would you prefer to be notified about this research, and gave them the option of preferring that the research using randomization not to be conducted. And we asked this of all those who wanted written permission in answer to that earlier question. And you can see that what happened is that in terms of the relative ranking of the priorities between the two, which is again something we've sort of heard from the advocates today, is they prioritize the research over consent. Most respondents said if there's a conflict so that it's not going to be practical to carry out the research, then if you have to have written consent, then I'd rather lower the stringency of the consent requirements but allow the research to go forward. And you can see that vast majority think that across all of the different scenarios, though the size of the minority that prefers the research not be conducted is larger for randomization and randomization for a serious condition compared to medical record research. We then asked, what if getting verbal permission or consent would make this research too difficult to carry out, and asked the same sort of questions, and asked that both of people who initially said we just want verbal permission, as well as the people who bumped from written notification to verbal permission. And again, vast majority say they would prefer that the research be conducted, valorizing the research over the stringency of the consent requirements in their responses. So most people, a very, very substantial majority of our respondents said if there's a trade-off between those two, let the research go forward. And then this gives you a sort of a gradient of the notification and permission across the research that we did, and you can see highlights the fact that we first asked this question of if written consent was too difficult, and then both groups who initially said verbal consent or who changed to verbal consent if that was too difficult to be able to obtain. Predictors for notification and permission preferences include, for more stringent preferences, being female, older, white race, higher education, greater understanding of ROMP, and perception of additional risk. Less stringent preferences, prior participation in a randomized clinical study, and greater trust in the healthcare system. We didn't give really very much of our PRIM&R data at all, but we just wanted to highlight one thing because it's just so striking. When you contrast the general population preferences and the way they look at it versus how IRB members, PRIM&R members, how people who are involved in the research setting look at these things, you can really see graphically how incredibly different these things are. While the general population really doesn't distinguish very much between medical record review and randomization in terms of their preferences, in contrast, people involved in the compliance system, PRIM&R members, see a huge difference between those two, with a much, much larger majority thinking that you needed to have written consent and or at best discussion and verbal consent compared to a medical record review. So while PRIM&R members see a large difference between medical record review and randomization with regard to the notification preferences, that difference is not pronounced at all with the general population. In terms of their perceptions of risk, and we're not going to say very much about this, but there was a perception of additional risk across all three proposals. The vast majority didn't see a lot of risk in research on medical practice, even for randomization for a serious condition, but they thought there was at least a little, and a decent number thought there was a lot. And while there are some statistically significant differences between the three scenarios, they're pretty modest. And so in general, again, the risk perception seems to be much less stringent between these things, which again, regulatory system and research ethics suggest are very, very different in terms of their risks. Some of our next steps for our study, we're obviously still in the analysis stage. Our paper from our qualitative studies have already been submitted, and we're nearing completion of our analysis of our first quantitative paper, presenting some of this data that we'll be submitting shortly, and we're going to continue to analyze the data and continue. We're also having a survey of patients who are actively engaged in a health system who are too ill to be the kinds of people who can fill out surveys to see whether there's a difference between their responses and the responses we got from our survey. We want to do some follow-up phone interviews of study participants to further drill down and explore some of the issues that we got in our surveys. And then we received a grant from the Greenwald Foundation to actually evaluate the impact of the different ways of communicating about this research to patients, and in particular to contrast what happens with our animated video that we used in the ROMP study with our illustrative narrative comics that were also developed as part of the study, with a just general informational video and the control of the general kinds of information, to see whether or not this makes a difference in terms of likelihood to participate, knowledge, as well as influences different attitudes. So we want to do a follow-up study of that with a Greenwald grant that we've received. I want to end with some of the implications of our work for the OHRP guidance. In randomized ROMP, some participants get treatments that differ from what they otherwise would have received had they not been in the research. Therefore, and according to the guidance, the purposes of the research, such as evaluated endpoints, are reasonably foreseeable risks of participating in the research, and as a result, most randomized research on medical practice is more than minimal risk, which makes a waiver of documentation or waiver or alteration of consent impossible under our current regulatory system. So most people in our survey support research and also prefer written informed consent, but if they are in conflict because research would be too difficult to carry out, the vast majority of respondents say research should take place anyway, again in contrast to the guidance. Relatively little difference in notification preference for randomization versus medical record review, in contrast to how most PRIM&R members look at it and in contrast to what the OHRP guidance would suggest. And just taking a slight step back, in general, what our qualitative data and to some extent our quantitative data highlights is, in a way, the way we tend to frame things in the regulatory system through the lens of risk is really not that significant for the way in which patients and the public frame these issues. Risk is just not as significant compared to trust and relationships, which they see as really the most important thing and the most important driver. Thank you very much.